I want you to imagine just for a second that you're sitting in a brightly lit, maybe slightly chaotic emergency room waiting area.
Yeah, the classic 2 a.m. ER visit. We've all been there, or at least we can picture it.
Right, exactly. You're exhausted, and suddenly the automatic doors slide open, and a parent rushes in carrying a young child.
And immediately before you even see them, you hear it.
Yes, before the triage nurse even looks up, you hear this terrifying, brassy, metallic sound every single time the kid breathes in.
It sounds almost exactly like a seal barking, just echoing off those hard linoleum walls.
It really does. It's loud, it's incredibly dramatic, and it instantly makes your own chest tighten just listening to it. You look over, the child is coughing violently, just making this massive racket.
It's the kind of sound that completely dominates a room. I mean, every head in that waiting area is going to turn.
Oh, absolutely.
It triggers this very primal alarm bell in the human brain. You hear that and you think, somebody do something.
Exactly. You'd think, okay, this is the most critical emergency in the hospital right now. But then, say, 10 minutes later, those same automatic doors slide open again. Another parent, another child.
But this time, it's a completely different scene.
Right. There is no dramatic barking.
Hmm.
In fact, the kid is perfectly quiet. They're just sitting completely still in their parents' arms, leaning forward a bit.
Mouth wide open.
Yeah, mouth open, drooling. They look pale, just utterly exhausted, staring blankly ahead. And they are barely making a sound at all.
Which is chilling in its own way.
It is. But human instinct, and frankly just everyday common sense, would tell you that the exceptionally loud, violently coughing child making the seal noise is the one in immediate, life-threatening danger.
Right. You would think so, yeah.
But counterintuitively, in the world of pediatric medicine, it is the quiet child.
The one sitting completely still.
Exactly. The quiet one who is drooling is quite literally moments away from a massive, catastrophic medical crisis.
Which is just wild to think about. It's one of the most profound and honestly terrifying paradoxes we see in clinical practice.
Yeah.
The noise of the first child scares you, absolutely. But the silence of the second child, that silence can kill.
Because they don't even have the energy to make a sound, right?
Right. It indicates a system that is failing so fundamentally that it doesn't even have the physical space or the energy left to make a noise.
Okay, let's unpack this, because our mission today is to execute a really comprehensive, deeply practical analysis of acute inflammatory upper airway obstructions.
A mouthful, but so important.
Totally. We're going to decode the big three pediatric airway emergencies. So that's viral croup, acute epiglottitis, and retropharyngeal abscess.
The heavy hitters.
The heavy hitters, yeah. And we are going way beyond just textbook lists of symptoms today on this deep dive. We want to understand the why and the how. Like, how does a virus actually hijack the vocal cords?
Or why does a bacterial infection turn a simple throat structure into a lethal trapdoor?
Exactly. And understanding this isn't just an exercise for, emergency room physicians.
Not at all. I mean, knowledge is most valuable when it's understood and applied across different contexts.
Right. So whether you are a medical student terrified of missing a diagnosis on your pediatric rotation, or a parent navigating the absolute nightmare of cold and flu season, or just a curious mind.
Grasping these distinctions is an incredible mental toolkit to have.
It really is. Knowing what a truly toxic presentation looks like versus a loud but manageable one.
It highlights the brilliant but ultimately incredibly fragile engineering of the human respiratory system. But to truly grasp the pathology, we really have to respect the anatomy first.
Okay, so before we can understand the diseases, we must understand the battleground. Let's lay down the architectural map of the airway, because this specific geography dictates every single symptom we're going to talk about today.
Yeah, you can't just point to the neck and say, oh, it's the throat, and call it a day.
Right. We have to divide this territory up.
Precisely. In the clinical world, we don't look at the airway as one long tube. We draw a very hard functional border right at the vocal cords.
The glottis.
The glottis, exactly. The vocal cords act as this geographic dividing line. So everything above the vocal cords is what we call the supraglottic airway.
Supra meaning above.
Right. And everything below the vocal cords is the subglottic airway.
Okay, so above the cords and below the cords. So if we map our big three conditions onto this geography, epiglottitis and retropharyngeal abscesses are supraglottic.
Correct. They happen above that border.
Right, or outside the main central pathway entirely. Meanwhile, croup is subglottic. It's happening below the vocal cords. But I have to ask, Why does this location matter so intensely?
Like a great question.
Like, why do we care if the millimeter of swelling is an inch higher or an inch lower in the neck?
Right. If we connect this to the bigger picture, it ultimately comes down to fluid dynamics, physics, and honestly, the terrifying lack of space in a child's neck.
Right, they're so small.
Yeah, the upper airway of a child is not just a miniaturized version of an adult's airway. It is anatomically completely distinct.
The cartilage is softer, right?
Much softer, it's more pliable, and the entire structure is just incredibly narrow. In an infant, the narrowest part of the entire airway isn't at the vocal cords like it is in adults.
Oh, really? Where is it?
It's actually below them, in the subglottic space, right at the cricoid cartilage. To give you a real sense of scale here, a newborn's airway might be only 4 millimeters wide.
4 millimeters. I mean, I'm trying to picture that. That is roughly the width of, like, a cheap plastic drinking straw.
That's a perfect comparison.
And that is the only corridor keeping that child oxygenated.
Exactly, just a few millimeters of clearance. Now, we have to bring in some basic physics, specifically Poiseuille's law.
Okay, lay some physics on me.
So in fluid dynamics, this law states that the resistance to airflow through a tube is inversely proportional to the radius of that tube to the fourth power.
To the fourth power, okay.
This is the mathematical reality that keeps pediatricians awake at night.
Let's break that math down so I can actually visualize it, because radius to the fourth power sounds intense.
Let's say you have a tiny airway with a radius of just 2 millimeters. It's working fine.
Okay.
Now you introduce a tiny bit of inflammation, like a viral infection that causes the mucosal lining to swell inward by just 1 single millimeter.
Right.
In an adult with a wide airway, 1 millimeter of swelling is just a sore throat. But in our child, that 1 millimeter of swelling reduces the radius from 2 millimeters down to 1 millimeter.
Oh, wow. It cuts it in half.
Yes, but because of that fourth power rule, you aren't just decreasing the airflow by half.
Yeah.
The resistance to airflow increases by a factor of 16.
Wait, 16 times?
16 times. A child goes from breathing comfortably to having to work 16 times harder just to pull the exact same volume of air to their lungs.
That is insane. 16 times the effort for a single millimeter of swelling. It's like this exponential trap.
It really is.
I like to think of the upper airway like a complex plumbing system to kind of make sense of this supraglottic versus subglottic divide.
I like that. Walk me through it.
Okay, so you have this wider, softer funnel at the top, right? That's the supraglottic area. This is where your tongue, your tonsils, your epiglottis live.
Right.
It's fleshy, it's movable, and its main job is to direct traffic, making sure air goes to the lungs and food goes to the stomach.
Exactly.
Then, that wide funnel narrows down into a rigid cartilaginous pipe at the bottom, the subglottic area leading down to the trachea.
The windpipe.
Right. So if you get a clog in that wide, fleshy funnel at the top, it's going to profoundly affect how you swallow, how your voice resonates. It might make your voice sound muffled, like you have a hot potato in your mouth.
The classic hot potato voice, yeah.
But if you get a swelling inside that narrow, rigid pipe at the bottom, the air is forced through a tiny, inflexible slit.
Which causes turbulence.
Yes. That creates a violent, high-pressure, turbulent whistle or burp. So the system makes completely different noises and requires totally different emergency tools depending on whether the clog is in the funnel or in the pipe.
That's a highly accurate and honestly really useful way to visualize it. Swelling above the cords in that fleshy funnel interferes heavily with the mechanical structures that protect the airway and facilitate swallowing.
Which is a super complex mechanical act.
It is, and that's exactly why you see a child drooling. They literally cannot swallow their own saliva without agonizing pain or without risking choking.
Wow.
On the other hand, swelling below the cords in the rigid pipe doesn't usually affect the mechanics of swallowing. They can swallow fine.
But the airflow is wrecked.
Exactly. It drastically and exponentially restricts the volume of airflow reaching the lungs, creating that harsh, turbulent noise as the air violently shears past the inflamed tissue.
Okay, let's dive right into that rigid pipe then. Let's talk about the subglotting space and our first condition, viral croup.
Which goes by the terrifyingly long clinical name of acute laryngotracheobronchitis.
I'm just going to stick with croup.
Probably for the best.
So this is the most common cause of stridor, that noisy, vibrating, whistling breathing in preschool children. And we're starting here to establish a baseline, right? We need to know what a loud but often non-toxic presentation looks like before we get into the really dark stuff.
It is incredibly common. If you spend any time whatsoever working in a pediatric emergency department or a primary care clinic, or, if you just have a couple of kids in daycare, you'll eventually see croup,
It's unavoidable.
pretty much. And as the name implies, nearly all of these cases are viral. This isn't a bacterial invader. It's a virus hijacking the mucosal cells.
Right. So when we look at the clinical epidemiology, the parainfluenza viruses, specifically types 1, 2, and 3, are the absolute heavy hitters here.
Yeah, they account for a massive 75% of all croup cases.
75%. Wow. They just have a biological affinity for the epithelial cells in that subglottic space.
They love that real estate.
But they aren't the only ones, right? You can also see croup triggered by adenovirus, RSV, enteroviruses, and even measles in unvaccinated populations.
Yes, and there's even a tiny fraction, maybe 3 to 4%, caused by an atypical organism called Mycoplasma pneumonia.
Okay, but overwhelmingly, 95 times out of 100, we are dealing with a viral invader that has taken up residence just below the vocal cords.
Overwhelmingly. And these specific viruses have a very defined demographic they love to target. The peak age for croup is between 6 months and 3 years old, sometimes pushing up to 5 years.
Why that specific window?
Because that is the exact window of time when the child's immune system is naive to these common viruses. And critically, their subglottic airway is at its absolute narrowest relative to their body's oxygen demands.
That makes perfect sense. The pipe is smallest right when they are encountering the virus for the first time.
Exactly. It also has this fascinating relationship with environmental factors and weather patterns. You see dramatic, predictable spikes during specific seasons.
Like winter.
Right. It flares up during the cold winter months in temperate climates. But interestingly, it also surges during the rainy and harmattan seasons in regions like Nigeria and West Africa.
I always find that detail so interesting, like how a dusty, dry, incredibly arid trade wind like the harmattan can trigger a massive respiratory surge in pediatric wards just as effectively as a damp, freezing winter in London or New York.
It's all about the environmental stress placed on that fragile mucosal lining.
Right. Cold air or intensely dry, dusty air damages the cilia, right? Those tiny hairs that sweep mucus away.
Yes, it damages the cilia and dries out the mucosa, essentially laying down the red carpet for the parainfluenza virus to invade.
So the virus moves in, the subglottic space gets inflamed, the radius shrinks, the resistance quadruples, and we get the classic presentation. Let's talk about the triad of croup.
The clinical triad is the signature of the disease. If you see these three things, you are looking at croup.
Okay, what are they?
First, the barky cough. You described it perfectly in our waiting room scenario. It is a brassy, metallic, hollow sound. It genuinely sounds like a sea lion or a seal barking.
It does not sound like a normal wet chest cough.
Not at all. Second, hoarseness of the voice or the child's cry. This happens because the inflammation is creeping right up to the underside of the vocal cords, altering how they vibrate.
Oh, that makes sense. Because it's subglottic, it's pushing up against the cord.
Exactly. And third, inspiratory stridor.
Let's pause on stridor, because it's one of those medical words that sounds exactly like what it is. Stridor.
It really does.
It's this harsh, high-pitched, vibrating, raspy sound when the child breathes in. It's literally the sound of air violently squeezing through a tube that has been narrowed by swelling.
Yes.
But here is the crucial, absolute key point, right? Despite making this terrifying noise, despite coughing so hard they look like they might crack a rib, the child with croup is typically not toxic looking.
That is the vital life-saving distinction a clinician must make in the first 5 seconds of walking into the room.
Because toxic doesn't just mean sick.
Right. When we use the word toxic looking in pediatric medicine, we aren't just saying the kid looks like they have a cold. We mean a child who looks profoundly, systemically poisoned.
Like they are shutting down.
Yes. They're lethargic, their skin is ashen or mottled, they are utterly unresponsive to their environment, they make poor eye contact, and they show absolutely no interest in their parents or toys.
It's a systemic collapse.
Exactly. A child with croup, on the other hand, might be highly distressed. They're coughing loudly, their chest might be heaving, but their central nervous system is intact.
You're awake.
They're alert. They recognize their parents. They might reach for a bottle between coughing fits. They might even be playing with a stuffed animal on the exam table.
And their fever.
They typically only have a low-grade fever, maybe 38 degrees Celsius, so about 100 degrees Fahrenheit. Their body is fighting a localized fire in the windpipe, not a systemic collapse.
And there's this weird, almost supernatural temporal phenomenon with croup. It mysteriously and reliably worsens at night.
Like clockwork.
Yeah. A parent will put their kid to bed at 7 p.m. with what seems like a totally normal, mild runny nose. And then by midnight, they're rushing down the highway to the ER with a child sounding like a barking seal. Why does this virus seemingly check a watch and flare up in the dark?
It feels supernatural to a terrified parent, but it's actually a fascinating combination of physiological and environmental factors converging all at once.
Okay, what's the first factor?
First, endocrinology. Endogenous cortisol, which is your body's natural built-in anti-inflammatory steroid, follows the circadian rhythm.
Right.
It naturally dips to its lowest levels in the middle of the night. With less natural steroid circulating, the viral inflammation is allowed to peak.
Oh, wow. So your natural defense is just asleep at the wheel.
Essentially, yes.
Yes.
Second, gravity.
Gravity.
Think about it. When a child is running around during the day, gravity helps drain fluid from the upper airway. When they lie flat in bed for several hours, blood and interstitial fluid pool in the tissues of the neck and upper airway.
Which physically increases the congestion and swelling.
Exactly. Combine that drop in cortisol and that pooling of fluid with the cooler night air in the bedroom, which can cause mild bronchospasm and irritate the airway, and you get the classic terrifying midnight croup flare.
That makes perfect mechanical sense. Okay, let's look at how we diagnose this when they actually get to the hospital. Obviously, the clinical presentation, the bark, the stridor, the non-toxic appearance, that's usually enough for an experienced doctor to make the call without any tests.
Yeah, you can usually diagnose croup from the hallway.
Right. But if you do need confirmation, or if you do an AP, an anterior posterior neck X-ray, meaning shooting the X-ray beam from the front of the neck to the back, you see something very specific. Radiologists call it the steeple sign, or the pencil tip appearance.
Visualizing this is incredibly helpful. Imagine a normal, healthy windpipe on an X-ray. It should look like a wide, rectangular, uniform column of black.
Because X-rays pass right through air, so air shows up as black on the film.
Right. The tissue around it is white or gray. But in croup, the subglottic tissues, the walls of that pipe, swell inward toward the center.
So it pinches.
Exactly. So instead of a wide, uniform rectangle, that black column of air papers up into a sharp, narrow point just below the vocal cords.
It looks exactly like the pointed steeple of a classic church.
Or the tip of a freshly sharpened pencil. That tapering is the visual photographic proof of the obstruction. You're literally seeing Boissou's law in action on the film.
So we have our barking, relatively alert, non-toxic child with a steeple sign on their X-ray. How do we fix it? The treatment protocols seem surprisingly straightforward for how dramatic the symptoms are, but they are highly, highly effective.
They are, and it's a testament to understanding the mechanism of the disease. For outpatient management, the first step is often environmental. Cold, humidified air, or cold steam from a nebulizer.
So the old advice of taking the kid outside into the cold night air actually works.
It really does. The moisture soothes the irritated mucosa, and the cold temperature causes mild vasoconstriction. It shrinks the swollen blood vessels in the airway, buying a little bit of space.
But the absolute heavy lifter, the cornerstone of croup management, is a single dose of a medication called dexamethasone.
Yes, usually given orally or via injection at 0.6 milligrams per kilogram of body weight.
Dexamethasone, that is a powerful corticosteroid, right? So we aren't giving them an antiviral to kill the parainfluenza virus.
No, not at all.
We are basically giving them a medication that tells their own immune system to stand down, stop freaking out, and stop swelling the airway shut.
That's exactly right. The virus isn't what's threatening the child's life. It's the child's own inflammatory immune response to the virus that is narrowing the tube.
Oh, wow.
Dexamethasone acts like a systemic fire blanket. It penetrates the cell nuclei and alters gene expression to drastically downregulate the production of inflammatory cytokines.
And the reason we use dexamethasone specifically and why that 0.6 millikilo dose is so important is because it has an incredibly long biological half-life, right?
Yes, up to 72 hours. So a single, precise, powerful strike is usually enough to break the cycle of inflammation completely without needing to send the parents home with a complex 5-day steroid taper.
That is incredibly efficient. But what if the child comes in and they are struggling right now? Like they are in moderate to severe distress, the stridor is loud even when they are just sitting calmly, and we don't have the 2 to 4 hours it takes for the dexamethasone to really kick in and work.
That's when we deploy racemic epinephrine, administered as an aerosolized mist through a nebulizer mask.
Adrenaline.
Exactly. Epinephrine binds directly to the alpha-adrenergic receptors in the mucosal blood vessels of the airway.
So it forces them to clamp down?
Yes, when it binds, it forces those blood vessels to rapidly constrict. It quite literally squeezes the fluid out of the swollen tissue and back into the systemic circulation.
That's amazing.
It shrinks the mucosa and opens the airway within minutes. It is a spectacular rescue medication, but its effects wear off in about 2 hours.
Ah, so it's a bridge.
Exactly. We use the epinephrine to instantly open the airway, which buys us the critical time needed for the dexamethasone fire blanket to take effect.
But not every kid gets to take their steroid and go home. There are strict admission criteria. You don't just send everyone back to bed.
No, definitely not.
If there is even a hint of suspected epiglottitis, which we will get to in a minute, you admit them. If there is severe or progressive stridor, while the child is just resting calmly.
Right. Resting stridor is a huge red flag.
If you see cyanosis, which is that terrifying bluish or purplish tint to the lips and skin caused by a severe lack of oxygen in the blood.
That means the system is failing.
If they have a depressed sensorium, meaning their mental state is slipping and they are becoming lethargic, or if they have a high fever and suddenly look toxic. Clinicians also use scoring systems, right? Like the Downs score or the Wesley-Krupp score.
Yes, looking at things like retractions, air entry, and cyanosis. If that score is high, say greater than 7, they are admitted immediately, possibly straight to the pediatric intensive care unit.
And the team might even have to prepare for nasotracheal intubation if the airway fails completely.
That's right. Because while croup is usually manageable and self-limiting, if that subglottic space closes completely, you transition from a respiratory distress scenario to an acute, lethal airway failure in minutes.
Now, in diving deeply into the inpatient management protocols, I noticed a really strict bolded warning. The protocol says, avoid opioids and sedatives as much as possible.
Yes, a massive, massive rule.
I have to be honest, my first instinct as a human being, if I see a child terrified, crying, coughing violently, and struggling to breathe, would be to give them something to calm them down.
It makes sense intuitively.
Right. If they are calm, they breathe slower. Wouldn't a strong pain or anxiety relief medication like an opioid help them relax their airway? Why is it an absolute textbook rule to avoid them?
It seems incredibly logical. Calming a panicking patient is usually step 1 in medicine. But in an obstructed pediatric airway, it is a lethal physiological trap.
Lethal. Wow.
Yes. Opioids do 2 specific things that are uniquely dangerous here. First, they have a powerful anticholinergic-like effect on secretions, meaning they dry up respiratory mucus.
Okay, so they stop making mucus.
But whatever liquid mucus is already pooling in that airway turns from a fluid into a thick, crusty, immovable plug.
Oh, God.
You are physically cementing the airway shut.
That's horrifying. And the second thing.
Second, and more importantly, opioids fundamentally depress the respiratory drive center in the brainstem.
Okay.
A child with croup needs to work hard to breathe. They need that elevated respiratory drive, that feeling of panic, to generate the massive negative pressure required to pull air past a 1 millimeter opening.
They have to fight.
They have to fight. If you chemically suppress their brain's drive to breathe, if you tell their brain, hey, everything is fine, go to sleep, they might just stop trying to pull air past the obstruction.
So they just quietly stop breathing.
They quietly slip into silent hypoxemia, carbon dioxide builds up, and they suffer a cardiopulmonary arrest.
That is wild. The very medication that would ease their fear essentially disables their only remaining survival mechanism. It turns off the alarm while the house is still on fire.
That's a great way to put it.
Okay, so croup is loud, it's scary, it sounds like a seal, but generally, the child doesn't look completely poisoned, and we have good physiological tools to manage it. But let's transition now.
Into the darker territory.
Yeah. What happens when the child doesn't have a barking cough? What happens when we go back to that second child in our waiting room, the one who is quiet, perfectly still, drooling, and looks profoundly, systemically sick?
We move out of the subglottic viral annoyance of croup, and we enter the supraglottic bacterial nightmare of acute epiglottis.
The toxic trap. This is our second condition, and the absolute contrast between the dramatic noise of croup and the terrifying, still quiet of epiglottitis is the core lesson of this entire deep dive.
Without a doubt.
Let's talk about the etiology. We aren't dealing with a virus anymore. What is causing this?
Unlike croup, epiglottitis is overwhelmingly a bacterial infection. And historically, we cannot talk about epiglottitis without talking about the terror of the 1980s pediatric ward.
Because it used to be way more common, right?
Unbelievably common. Before 1990, the most common cause of this disease, by a massive margin, was a specific bacteria called Haemophilus influenza type B, or Hib.
I've heard older pediatricians talk about Hib. They talk about it with a genuine shudder.
They do, because it was a monster. An ER doctor in the 80s would see cases of Hib epiglottitis constantly. A perfectly healthy child would develop a slight fever, and within 6 hours, they would be suffocating to death, requiring an emergency surgical airway slashed into their neck.
Within 6 hours, that is so fast.
It was fast, it was brutal, and it killed thousands of children. But then, the introduction of the widespread Hib conjugate vaccine in the late 80s and early 90s caused the incidence of Hib epiglottitis to plummet by over 99% in developed countries.
Over 99%.
Yes, it is one of the greatest, most unheralded triumphs of modern preventative medicine.
That is incredible. But the disease didn't disappear entirely. It's still a massive threat in areas with lower vaccination rates or in populations missing boosters.
Right.
And interestingly, because we wiped out the main bully, other bacterial culprits have stepped in to fill the void. When we look at cases today, we are often seeing Streptococcus pyogenes, which is the same bacteria that causes strep throat, along with Streptococcus pneumonia and Staphylococcus aureus, including MRSA.
So we're talking about heavy-duty destructive bacterial infections.
Right. And because it's bacterial, the presentation is vastly different from a viral cold. The child comes in with an abrupt, high-grade fever. We're talking 40 to 41 degrees Celsius.
That's over 104 degrees Fahrenheit.
They have a muffled voice, which the clinical text describes as aphonia. They don't sound hoarse. They sound like they literally can't speak at all.
That's voiceless.
They have an incredibly anxious, wide-eyed facial expression. And here is the kicker. Their stridor, their breathing noise, is notably quieter than even a common cold.
And they appear highly toxic.
Yeah. And interestingly, a cough is almost completely absent.
Let's visualize anatomically what is happening to create that specific cluster of symptoms. The epiglottis is a small, delicate, leaf-shaped flap of cartilage covered in mucous membrane. It's located right at the base of the tongue, at the very top of our fleshy supraglottic funnel.
Okay, the leaf.
Its normal, everyday job is to act like a trapdoor. Every time you swallow, it flips down to cover your windpipe, ensuring that food and water slide over it and into your esophagus, rather than falling into your lungs.
So it's protecting the pipe.
Exactly. But when it gets infected by these aggressive bacteria, it doesn't just get a little inflamed, it swells massively, rapidly, and intensely.
How big does it get?
It turns into what we describe clinically as a cherry red epiglottis. It goes from being a thin, delicate leaf to a huge, heavy, inflamed, blood-engorged ball sitting directly on top of the delicate airway opening.
Here's where it gets really interesting to me. It's the paradox of the quiet stridor. If a kid has this massive cherry red ball blocking their airway and they are actively suffocating, why are they quieter than a kid with croup?
It's all about physics again.
Right. If we go back to our analogies, let's think about a heavy manhole cover or a thick wooden trapdoor. When a door is mostly open and the wind catches it, it bangs and howls loudly.
Right, that's croup, air vibrating through a rigid pipe.
But when that heavy, swollen trapdoor is almost completely, terrifyingly shut, the air can only squeeze through a microscopic, millimeter-thin crack.
Exactly.
The system doesn't have the space or the velocity to bang anymore. It just makes a faint, high-pitched, desperate whistle. That's epiglottitis. The utter silence is actually a direct measure of how little air is managing to move past the trapdoor.
That is exactly right. The silence is the sound of imminent failure. What's fascinating here is how the child's body instinctively, mechanically reacts to this microscopic crack of an airway.
You mentioned in the intro that the child is sitting perfectly still.
Yes. Yeah. They aren't thrashing around. They adopt a very specific, highly diagnostic posture called the tripod position.
Like a camera tripod.
Exactly like a camera tripod. They sit upright, in bed, or on their parent's lap, leaning forward, resting their entire upper body weight on their hands or knees out in front of them.
Okay.
Their mouth is wide open, their neck is hyperextended, meaning their chin is thrust far forward and up into the air, and they are drooling a continuous stream of saliva.
My first thought is that they're drooling simply because it hurts too much to swallow. A swollen throat equals pain.
Pain is certainly a factor, but primarily it is pure mechanical survival.
Survival. How so?
The drooling happens because the supraglottic funnel is totally blocked by that cherry red ball. They physically cannot swallow saliva without risking aspirating it into their lungs, or worse, triggering that heavy trapdoor to flip down and completely seal the airway shut.
So they just let it run out of their mouth.
Exactly. And the tripod position itself is not just a symptom of fatigue. It is a brilliant desperate physiological reflex.
To get air.
Right. The child is instinctively trying to re-engineer their own anatomy. By thrusting their chin forward and leaning over, they are physically pulling the structures of the neck into a perfectly straight line, using the muscles of the jaw and neck to lift that heavy, swollen epiglottis just a fraction of a millimeter off the windpipe.
That is amazing.
If you take that child and force them to lie flat on their back to examine them, that heavy lid drops backwards, gravity takes over, and the airway closes completely. They will arrest in seconds.
Which brings us to the lethal mistake.
Yes, the cardinal rule.
The absolute cardinal rule of emergency medicine that is bolded, highlighted, and underlined in every single pediatric protocol in existence. Let's say I'm a well-meaning clinician. I see a child with a fever, drooling, complaining of a sore throat. My instinct is to say, open wide, grab a flashlight, and stick a wooden tongue depressor into their mouth to see how bad the swelling is.
Please don't.
If I suspect acute epiglottitis, why is doing that considered a catastrophic medical error?
Wait, you're saying a simple wooden stick can kill them? Literally within seconds. It's because of a neurological reflex called laryngospasm. The tissues of the supraglottic airway in a child with epiglottitis are wildly inflamed, highly vascularized, and incredibly hyperreactive. The vagus nerve, which supplies sensation to this area, is on a hair trigger.
Okay, so it's super sensitive.
Incredibly. If you introduce a foreign object, like a wooden tongue depressor, and you touch the back of the tongue or the pharyngeal wall, you trigger a gag reflex.
You're right. Everyone gags.
In a normal, healthy person, you gag, maybe you cough, it's unpleasant. But in a child with epiglottitis, when that gag reflex fires, the brainstem sends a massive motor signal to the laryngeal muscles. The muscles spasm violently, and that heavy, swollen epiglottis clamps down over the airway, opening like a steel vault door.
To protect the lungs from the stick.
Exactly, to protect the lungs from what it perceives as an invading object. And here's the absolute tragedy. Because of the massive swelling and the altered geometry, once it clamps down, gets wedged.
It gets stuck.
It will not reopen. You take a child who is hanging on to life by a literal millimeter of airflow, and you instantly cause an acute, complete respiratory obstruction. You induce cardiopulmonary arrest. You literally kill the patient by trying to examine them.
That is absolutely terrifying. A simple wooden stick becomes a lethal weapon. So if I'm a doctor and I have a toxic, drooling child in a tripod position, how do I confirm the diagnosis if I can't look inside their mouth? Do I take an X-ray?
Diagnostics for epiglottitis are highly controlled, militaristic operations. You never, ever send an unstable, drooling child in a tripod position to the radiology suite alone just to get an X-ray.
Right, because if they obstruct in the elevator, they die alone.
Exactly. The clinical presentation alone dictates the emergency response. The gold standard for actual visualization is direct laryngoscopy, using a metal blade and a camera to look down the throat.
But wait, didn't you just say no looking?
Pediatric protocols are emphatic. This must only be done in the operating theater, not in the ER bay, not in the pediatric ward. You transport the child sitting upright to the OR.
Okay, so you move them super carefully.
You assemble a fully prepped surgical team, a senior anesthesiologist, an ENT surgeon, and you have a rigid bronchoscope and a surgical tracheostomy kit already open and ready on the sterile table. Only then do you look. And if you see the cherry red epiglottis, you immediately place a breathing tube.
Let's talk about the X-ray, though, because if the child is stable enough, or if the diagnosis is somehow ambiguous, a lateral extended neck X-ray, taken from the side, shows a very famous radiographic sign. If croup gives us the steeple sign from the front, epiglottitis gives us the thumb sign from the side.
Exactly. On a normal lateral neck X-ray, the epiglottis looks like a thin little finger or a delicate curved shadow floating above the airway. In epiglottitis, because it is so engorged with blood and pus, it balloons out.
What's a thumb?
Yes. On the black background of the airway, it looks exactly like a large, rounded, swollen human thumb pressing firmly into the windpipe. It's unmistakable. But again, you only get that film if you have a portable X-ray machine brought to the bedside, or if the child is completely accompanied by an airway expert.
Let's talk about the emergency response once we know what we're dealing with. The treatment section for this reads like a wartime protocol. This is an ABC emergency: airway, breathing, circulation.
The absolute first priority, before treating the fever, before treating the bacteria, is securing patency.
So the protocols dictate nasotracheal intubation, sliding a plastic breathing tube through the nose, past the epiglottis, and into the trachea under general anesthesia. Or if the swelling is too massive, an emergency surgical tracheostomy cut directly into the neck.
Yes.
And critically, the protocol states you intubate regardless of the perceived level of respiratory distress. Wait, even if they seem to be breathing okay in their tripod position, you still knock them out and intubate?
Yes, absolutely. Because epiglottitis is notoriously deceptive. A child can maintain that tripod position and breathe through a 1 millimeter crack for hours, looking seemingly stable, and then muscle fatigue sets in.
Oh, because they're holding their entire body up.
Exactly. The moment their neck muscles tire, the epiglottis drops, and they completely obstruct in a matter of seconds. You do not wait for failure. You secure the airway proactively. Once that rigid plastic tube is successfully guided past the swollen cherry red mass and into the lungs, the immediate life threat is over. You've bypassed the trap door.
Okay, so the plastic tube is in, they're breathing. Now what? The protocol says to keep the patient NPO.
NPO means nil per os, or nothing by mouth. Because the supraglottic funnel is totally compromised, they cannot swallow. If you give them a sip of water, it will pool and potentially aspirate around the tube. You provide intravenous fluids for hydration, and you provide humidified oxygen through the tube.
And then with the airway secured, you launch a massive chemical counterattack against the bacteria.
It's carpet bombing time.
We look at the IV antibiotics. The standard of care is a 7 to 10-day course of heavy-hitting drugs. Ceftriaxone, ampicillin combined with sulbactam or cefotaxime, plus IV steroids like hydrocortisone to rapidly reduce the massive tissue swelling. Why these specific antibiotics? Why not just, standard penicillin?
The choice of ceftriaxone, or cefotaxime, which are third-generation cephalosporins, is highly strategic. We need antibiotics that offer excellent broad-spectrum coverage. But more importantly, we need drugs that can easily cross the blood tissue barriers into highly inflamed, pus-filled tissues.
So they have to penetrate deep.
Right. These drugs target the cell wall synthesis of Haemophilus influenza and the Streptococcus species, causing the bacteria to literally burst open and die.
You mentioned ampicillin. Ampicillin alone used to be the gold standard decades ago, right? But bacteria are smart. Many strains of H. influenza evolved to produce an enzyme called beta-lactamase.
Yes, a classic resistance mechanism.
Which acts like a pair of chemical scissors that cuts the ampicillin molecule in half, rendering it completely useless. So we outsmarted them back. We add sulbactam.
Exactly.
Sulbactam doesn't kill bacteria. It acts as a sacrificial shield. It binds to those bacterial scissor enzymes and destroys them, allowing the ampicillin to sneak in behind it and destroy the bacterial cell wall.
That is brilliant molecular warfare happening while the plastic tube keeps the kid alive. And usually, because these antibiotics are so effective, the swelling goes down rapidly. The protocols note that extubation, removing the breathing tube, is often possible after just 48 to 72 hours in the ICU.
You literally just buy them 3 days of breathing while the drugs do the work.
Exactly. But you have to monitor them intensely during that time. Because these bacteria are swimming in the bloodstream, you have to watch for systemic complications.
Like what?
The infection can seed other organs, causing meningitis, which is infection of the brain lining, pneumonia, septic arthritis in the joints, or even mechanical complications like mediastinal emphysema and pneumothorax.
Wait, pneumothorax, a collapsed lung. How does a throat infection collapse a lung?
It's caused by the extreme negative pressure the child was generating in their chest while fighting to breathe before you intubated them. They pulled so hard they popped a lung.
That's horrifying.
If left untreated, the prognosis of epiglottitis is grim. Historical data states that up to 60% of patients will die without intervention. It is the very definition of a time-critical, zero margin for error medical emergency.
So we've covered the rigid pipe of the subglottic space with croup and the inflamed, swollen trapdoor of the supraglottic space with epiglottitis. Let's transition to our third and final pathology. We are moving anatomically backward.
Right.
The listener now understands the internal airway threats, the swelling inside the tube. But what happens when the airway itself is perfectly healthy? But the danger is lurking, growing in the walls directly behind it. We're talking about retropharyngeal abscess, the hidden wall.
This is a perfect anatomical progression. Now define the geography again, because this is all about spaces you probably didn't even know you had.
Okay, take me there.
Behind the muscular tube of your pharynx, which is the back wall of your throat, and in front of the prevertebral fascia, which is the tough, fibrous connective tissue covering the bones of your cervical spine, there is what anatomists call a potential space.
A potential space, meaning normally there's nothing actually there, just 2 layers of tissue sliding against each other like 2 pieces of wet glass.
Precisely. It's a microscopic lubricated gap. It exists to allow your pharynx to glide smoothly against your spine when you swallow a large piece of food or when you turn your neck aggressively.
So it's just a sliver of space for movement.
Right. But the terrifying problem with potential spaces in the human body is that if bacteria manage to get inside them, that space becomes an actual space.
Oh,
The
no.
bacteria multiply, the immune system attacks them, millions of white blood cells die, and the space fills with pus. It becomes a localized, pressurized cavern of infection.
And a collection of pus in that specific space behind the throat is a retropharyngeal abscess. When we look at the etiologies, the microscopic culprits here, Group A beta-hemolytic streptococcus is a major player, along with nasty oral anaerobes.
Bacteria that thrive without oxygen.
Yeah, and our old enemy, Staphylococcus aureus. But how on earth do these bacteria bypass the throat and get deep into a potential space against the spine in the first place?
It usually starts in one of two ways. Most commonly, in young children, it's a downstream complication of a seemingly routine illness. A child gets a bad bacterial pharyngitis, like a severe strep throat.
Okay.
The infection drains into the local lymph nodes located in that retropharyngeal space. Those lymph nodes become overwhelmed, they suppurate, meaning they break down and liquefy into pus, and they form an abscess.
Okay, so it drains back and gets stuck. What's the second way?
The second way is purely mechanical, and it's a classic pediatric trauma scenario. It could be a wound infection following a penetrating injury to the posterior pharynx.
Like from a toy.
Picture a toddler running across the living room with a popsicle stick, a toothbrush, or a hard plastic toy in their mouth. They trip and fall face first. The stick jabs violently into the back of their throat, puncturing the mucosal wall.
Ouch. But that doesn't seem like it would cause an abscess.
It doesn't look like a terrible injury from the outside, maybe just a little blood. But that stick just seeded millions of oral bacteria directly into that sterile potential space behind the throat. The puncture hole heals over quickly, trapping the bacteria inside to fester. Rarely, it can also spread forward from an infection in the spinal bones themselves, known as vertebral osteomyelitis.
So the bacteria are trapped, the pus collects, the space balloons out, and we get our clinical features. And they sound like a brutal, confusing mix of everything we've discussed so far. The patient often has a history of recent pharyngitis or minor trauma, followed by an abrupt onset of high fever.
Right.
They have severe difficulty swallowing and intense throat pain. They have noisy respiration, that stridor, and drooling, which makes it look suspiciously like epiglottitis.
Very similar at first glance.
But they also have extreme neck stiffness, they refuse to move their head, and crucially, if you were to look safely in a controlled setting with an anesthesiologist present, you might see a visible asymmetrical red bulge pushing forward on the back wall of the throat.
And here's the fascinating mechanical distinction. The noisy breathing, the stridor here, isn't because the airway itself is infected or inflamed. The vocal cords are fine. The epiglottis is fine.
Then what's making the noise?
The stridor is caused by mass effect. The abscess behind the throat is expanding like a high-pressure balloon. It is physically pushing the entire back wall of the throat forward, crushing the larynx and the airway from the outside in.
That is horrifying. It's essentially internal strangulation by an expanding pocket of your own infection.
Yes, external compression of the airway.
So for diagnostics, because we don't want to blindly stick things down a throat that is being crushed from behind, we go back to our trusty lateral extended neck x-ray. And the diagnostic marker here is pure geometry.
It is entirely geometric and very easy to spot if you know what to look for. On a normal lateral x-ray, the distance between the back of the black airway column and the front of the white vertebral bones should be incredibly thin, just a few millimeters of soft tissue.
Just that tiny potential space.
Right. But in a retropharyngeal abscess, that soft tissue space widens dramatically. The clinical cutoff rule of thumb is that if the retropharyngeal space swells to become greater than 50% of the width of the adjacent vertebral bone, you are looking at an abscess.
So if the gray shadow is more than half as wide as the bone next to it, that space is full of pus.
Exactly.
I want to pause on the complications section for this disease because this is where I actually gasped when reading through the clinical realities. I logically knew an expanding balloon of pus could obstruct the airway, and I knew that if that thin wall of throat tissue finally gave way, the abscess could rupture into the pharynx, causing the child to aspirate a massive volume of pus directly into their lungs while they sleep. That makes horrifying sense.
It's a major risk, yes.
But the pediatric textbooks also list complications like erosion into major blood vessels and mediastinitis leading to rapid multi-organ dysfunction.
Wait, A sore throat and a pocket of pus can lead to an abscess that eats into your major blood vessels.
This raises an incredibly important question about the interconnectedness of head and neck anatomy. The neck is a superhighway of vital structures packed into a tiny cylinder.
Right.
And those potential spaces in the neck are not fully sealed off vaults. They're separated by microscopically thin sheaths of fascia.
If an abscess builds up enough pressure and it isn't drained surgically, the enzymes and toxins released by the bacteria start digesting the surrounding fascial tissues. If the abscess eats laterally out to the side of the neck, it hits the carotid sheath.
And the carotid sheath houses.
It houses the carotid artery, which supplies blood to the brain, and the jugular vein. The enzymes can quite literally digest the wall of the carotid artery, causing a catastrophic, uncontrollable internal hemorrhage.
Wow. And the mediastinitis. The mediastinum is the central compartment of the chest cavity that holds your heart, the aorta, and the trachea, right? How does a throat infection get all the way down into the chest?
Gravity and fascial planes. The retropharyngeal space doesn't stop at the neck. It acts exactly like a vertical elevator shaft extending from the base of the skull all the way down into the superior mediastinum in the chest.
Oh my God.
If the pus isn't drained, it takes the path of least resistance. It travels straight downward along that fascial plane, riding the elevator shaft into the chest cavity.
Surrounding the heart.
Exactly. An infection that surrounds the heart and the great vessels is called mediastinitis. It is one of the most lethal infections in medicine. It has a staggeringly high mortality rate because it rapidly triggers overwhelming systemic sepsis, coats the heart in pus, and causes multi-organ failure.
So a toddler tripping with a plastic toothbrush in their mouth could, over the course of a week, theoretically end up with an infection digesting their carotid artery or surrounding their heart. The human body is a terrifyingly fragile machine. How do we treat this to make sure that absolute worst-case scenario doesn't happen?
The treatment must be definitive, structural, and aggressive. While medical management with IV antibiotics is initiated immediately, using drugs like ampicillin plus sulbactam, ceftriaxone, or amoxicillin given parenterally, meaning intravenously to bypass the digestive tract, along with heavy pain medication.
Right.
But antibiotics alone are often not enough. You cannot just rely on an IV drug to penetrate a thick-walled, vascular, pressurized pocket of pus. Blood doesn't flow through pus, so the antibiotics can't reach the core of the bacteria.
You have to physically drain the swamp.
Exactly. The mainstay of treatment is surgical incision and drainage. The child is taken to the operating room, placed under general anesthesia with a secured airway. The ENT surgeon carefully accesses the back of the throat, makes a precise incision into the bulging wall, and uses high-volume suction to evacuate the purulent material.
Just vacuums it out.
They literally vacuum the pus out, relieve the massive pressure on the airway, and wash the cavity out with saline.
Once the physical volume of the abscess is gone, the airway decompresses instantly, the external strangulation is relieved, and then, with the fortress walls breached, the IV antibiotics can easily mop up the residual infection in the surrounding tissues.
Exactly. But obviously, when a child comes in with a stiff neck and a fever, a doctor has to rule out other things. You have to run through differential diagnoses.
We have to distinguish this from croup, which we now know how to do because of the bark and the non-toxic appearance.
Right.
But we also have to distinguish it from meningismus. That's a condition where the neck is stiff and there are signs of meningitis, but the spinal fluid is clear. The neck muscle is spasming because of a localized throat infection.
Correct.
We have to rule out simple lymphadenitis, just swollen lymph nodes, or even tuberculosis of the cervical spine, which can cause a slow-growing cold abscess in that exact same retropharyngeal space.
Medicine at this level is always about high-stakes pattern recognition and ruling out the dangerous mimics. You look at the whole picture, the sudden onset, the toxic appearance, the drooling, the specific radiographic signs on the lateral X-ray, and you make the call. You synthesize the data into a structural understanding of the threat.
So let's step back and summarize the clinical cheat sheet we've just built. Because if there is one thing this entire deep dive proves, it's how seemingly identical surface symptoms, like a kid struggling to breathe, point to entirely different physiological emergencies depending on just a few key variables. Let's lay out the matrix.
Let's run through it.
Scenario 1. Is the child toxic or non-toxic? If they have a loud, barky, metallic cough, a low-grade fever, their symptoms magically worsen at night, but they generally look alert, making eye contact, and non-toxic.
We are looking at viral croup. It's an internal subglottic swelling. The influenza virus is narrowing the rigid pipe. On an X-ray, we look for the tapering steeple sign.
And treatment.
We treat with cold, humidified air, a precise dose of dexamethasone to blanket the immune response, and maybe racemic epinephrine to buy time. But we absolutely, under all circumstances, avoid opioids so we don't cement their airway or blunt their drive to breathe.
Scenario 2. The child is terrifyingly quiet. They are highly anxious, leaning forward in a tripod position, drooling continuously, and they look profoundly toxic with a very high fever. There is no barky cough, just a faint, desperate inspiratory whistle.
That is acute epiglottitis, a supraglottic bacterial infection, historically Hay, but now often strep or staph. The heavy trapdoor is swollen shut.
And the warning.
The absolute cardinal rule: no tongue depressors or you will trigger a lethal laryngospasm. On a lateral x-ray, we look for the swollen thumb sign. We treat this as an immediate ABC emergency requiring prophylactic intubation in the operating room and heavy IV antibiotics to destroy the bacterial cell walls.
And the final scenario. A child with a recent history of a severe sore throat or a minor mouth trauma, sudden high fever, drooling, severe neck stiffness, and perhaps a visible bulging mass at the back of the throat.
That's a retropharyngeal abscess, an external compressive threat, a pressurized cavern of pus in the hidden potential wall behind the airway. On the lateral x-ray, the retropharyngeal space is dangerously widened, blowing past that 50% vertebral width marker.
Treatment.
We treat with aggressive surgical incision and drainage to instantly relieve the mass effect and prevent the infection from riding the fascial elevator shaft down into the heart.
So, what does this all mean? It means the clinical environment is one of extreme, unforgiving nuance. The difference between sending a child home with a dose of oral steroids and rushing them to an operating room for an emergency surgical airway hinges entirely on recognizing these minute differences in sound, in biomechanical posture, and in the patient's history.
In a world of medical information overload, this is where raw data transforms into actual life-saving clinical wisdom. Anyone can open an app and look up the dosage of dexamethasone or the spelling of ceftriaxone.
Exactly.
But critical thinking, recognizing the physiological why behind a child forcing themselves into the tripod position, or deeply understanding the devastating mechanical consequences of taking a simple wooden spatula into the mouth of a drooling, toxic child. That is where medical knowledge transcends textbooks.
It's the application.
Exactly. That understanding is how you save a life in the middle of the night. I'd ask anyone listening to this, what stands out to you about how perfectly distinct yet universally terrifying these presentations are?
For me, it's all about how the body brilliantly but desperately compensates for failure. And it leads me to a final provocative thought that I want to leave you with, something to mull over long after this deep dive ends. Think about the evolutionary arms race between our internal anatomy and these microscopic pathogens. The human throat is an incredibly crowded, intensely compromised piece of biological real estate.
It's asked to do too much.
Way too much. Evolution has forced it to handle complex, resonant speech, continuous high-volume respiration, and the physical digestion of solid food, all routed through one tiny millimeter-scale shared corridor. It is a massive design flaw held together by complex reflexes. The fact that a single millimeter of viral swelling below the vocal cords can create a mechanical sound that echoes through an entire hospital.
Or that a tiny, invisible collection of bacteria hiding behind a microscopic layer of fascia can threaten to digest your carotid artery or shut down your heart.
It's a deeply humbling reminder of our own biology. It forces you to respect the fragile microscopic engineering that flawlessly separates your air from your food and keeps you alive, silently, every single second of every single day, until suddenly it isn't silent anymore.